My name is Chuck Hicks. I'm an Associate Professor of Medicine in the Division of Infectious Diseases here at Duke University Medical Center.
And how long have you worked with HIV/AIDS patients?
Right. So, as I mentioned, I graduated from medical school in 1979. I started my internal medicine training in San Francisco, and that went between 79 and 82.
Where were you? What hospital?
I was primarily at a place called Letterman Army Medical Center, which was on the Presidio of San Francisco. And we had a training agreement with the University of California, San Francisco. So some of the work we did was at the UCSF hospital, including San Francisco General Hospital Emergency Department, where I had my first encounters with what we later learned was this new epidemic, HIV infection.
How was it when the first cases popped up?
So just a little historical context. The very first cases became known to the larger medical community in the summer of 1981. There was a report in the CDC Morbidity and Mortality Weekly Report of about 20 cases of pneumocystis carinii pneumonia, which was a very uncommon condition that used to occur in people with lymphoma or other very immunocompromising conditions, and now for the first time have been reported in previously healthy young homosexual men, and it was reported initially in Los Angeles, then shortly thereafter in San Francisco and New York. And this was really the first clinical recognition that there was a new condition, a new disease state that was affecting these young, otherwise healthy gay men in primarily large urban centers on the coasts. And so I was a resident in San Francisco, and of course a lot of the cases were being discovered there because there was a very large gay community in San Francisco. And of course, as the epidemic began to surface, that was the population that was really being infected.
What could doctors do for these patients?
Well, this was really a disturbing time. You know, I have to say in the early 80s, we had kind of reached a point in medical history where we thought that we had essentially all the answers to infectious diseases. We thought we have great antibiotics, we have wonderful sanitation, the food supply is safe. So in the United States, it seemed like infectious diseases were mostly a thing of the past. If you knew how to use our antibiotics, you were pretty much going to be fine. And suddenly we had a new disease that had not previously been encountered. We didn't even know what the cause of it was. And not only was it a new disease, but it was a lethal new disease. It took people who had previously been fine, and it made them really, really sick. And the way it made them sick was to allow for conditions that we'd almost never seen before, certainly hadn't seen in young, otherwise healthy people. These conditions suddenly were beginning to be diagnosed. So at the time, really, we were always kind of just reacting to the situation. We would see someone with cryptococcal meningitis, which we knew happened sometimes, and we had an idea of how to treat it, but we didn't know why this person would get this. We saw pneumocystis pneumonia, again, a very uncommon condition, and all of a sudden we're seeing cases that were occurring in people that you would never have anticipated they would get it. So our response at that time was just to sort of dig out the most appropriate conventional therapy that had been developed to treat these rare conditions. We were also seeing some disease states that we really hadn't encountered almost ever before. So cryptosporidium as a cause of intractable diarrhea and wasting, that was completely new. A progressive multifocal leukoencephalopathy. We really hadn't seen that in young people before.
What is that?
It's a degenerative disease of the brain that produces just a very awful constellation of mental deterioration, neurological impairment, and kind of relentlessly progresses to death in a most horrible way. And then, of course, one of the things I think people think about if they go back to some of the television shows, Angels in America, the Philadelphia Story, Kaposi sarcoma, these very obvious and disfiguring pigmented skin lesions on the face, on the arms and legs, that really were kind of like the brand this person's HIV positive, this person has AIDS. So we were facing something we really had not ever seen before in history, and our sort of hubris that infectious diseases were a thing of the past and we don't have to worry about this anymore was being brought to task, because obviously these were infections that were entirely unanticipated and for which our management was very lacking. So the first order of business was to try and figure out why it is that these young people were getting so sick and were dying in ways that we'd never seen before. And I think if you can use the word lucky and HIV in the same sentence, we were lucky in that the scientific tools of virology, of molecular diagnostics, of understanding how a new disease might have suddenly emerged in the clinic, those tools were pretty well advanced. And so it took us only, quote unquote, 4 years from these very first cases being recognized to when we had figured out what the cause was, and we had a diagnostic test, which was really critical, because you have to know who has the condition if you're going to try to approach it in a more rational way.
And that was a blood test?
And that was a blood test. In 1985, we were able to test people and say, do you have this new condition or not? And we were still, at that point, trying to figure out what to call it. It used to be called HTLV3, which is human T lymphotrophic virus number 3, or it was also known, the French term was LAV, lymphadenopathy associated virus. And as the groups that were working on this kind of sorted through the information they had and realized they both were sort of finding the same thing, a consensus new virus name was created called this human immunodeficiency virus, or HIV.